Good morning. I'm Dr. Vignesh from the Department of Conservative Dentistry and Endodontics. Today's topic is on non-carious cervical lesions, or otherwise called as NCCLs. So, to begin with, gradual loss of tooth structure is a physiologic process that occurs throughout life. Most often, it is so slow that it rarely poses any problem to the patient. So, this loss of tooth structure from the cervical region of the teeth occurs due to pathological processes like erosion, abrasion, and abfraction, which may act independently. So, these lesions are seen in half of the population, and prevalence increase with age. So the first NCCL we are going to discuss is about erosion. So this is a loss of tooth substance by a non-bacterial chemical process. The next is abrasion. Dental abrasion is a pathological wearing away of teeth due to abnormal process habits or abrasive substances. The last one is abfraction. This is a pathological loss of tooth structure due to biomechanical loading forces that result in flexure and ultimate fatigue of enamel and dentin at location away from loading. So we'll see the etiology of these NCCL lesions. So there are intrinsic and extrinsic factors for erosion. So the extrinsic factors include dietary acid, citrus fluids, carbonated drinks, pickled foods, and environmental erosions like wine tasting and metal plating. And intrinsic factors include all the GI disorders, eating disorders like anorexia nervosa, bulimia nervosa, chronic vomiting, and pregnancy in morning sickness. Then in abrasion, most probably it's due to mechanical wear and tear, due to tooth brushing, over vigorous brushing of tooth, improper brushing techniques, and abnormal habits such as biting of a pipe stem or a fingernail. Abfraction is mainly due to excessive or imbalanced occlusal forces and other parafunctional habits such as bruxism and clenching. Saliva actually plays a vital role in this. The quantity and the quality of saliva may also have a big role in developmental of NCCLs. Drugs and other conditions which reduce salivary flow can accelerate the loss of tooth structure in cervical region. Currently, it is accepted that NCCLs have a multifactorial etiology and they are not related to any one factor. A combination of erosion, abrasion, and abfraction may operate in the initiation and progression of these lesions. We will move on to the clinical features of these NCCLs. So, clinical features are described through these parameters: location, shape, margins, enamel surface, and the teeth affected. So in erosion, it is mostly seen in the facial and lingual surfaces, and facial and only facial surfaces in case of abfraction and abrasion. And in regards to shape, broad, shallow, and saucer-shaped lesions in erosion, wedge-shaped or V-shaped lesions in abrasions, and very prominent wedge-shaped lesions in abfraction. The margins of erosions are not well defined and it's mainly ruffled. There are good, sharp, and well defined margins in abrasion and pretty sharp margins in abfraction. The enamel surface looks smooth and polished in case of abrasion and abfraction, and in erosion it may show some roughness or grooves in case of abrasion. So the teeth affected, lingual surfaces of maxillary anteriors are most common for erosion lesions, and facial surface of maxillary canine to molar region in case of abrasion, and subgingival location of the premolars are seen in abfraction. So moving on to the diagnosis, history taking is one of the main key points to diagnose and characterize these NCCLs. We have to note down any history of intrinsic or extrinsic erosion. The dentist must try to identify digestive problems like anorexia, gastric regurgitation, etc. Patient's diet is a useful diagnostic tool. The dentist must also question about the abnormal habits like clenching, knife grinding, which may be possible factors for abfraction. So on clinical examination, these will show tooth mobility, open contacts, tilted or drifted teeth, atypical or occlusal wear, supraerupted teeth, cross bites, and fewer number of teeth, which is on occlusion. Then in radiograph, there will be an altered laminar dura with the widening of the periodontal ligament space, evidence of hypercementosis and resorption in some cases, and pulpal obliterations in case of abfractions. So the most common complaint from the patients will be tooth sensitivity due to the exposure of dentin on the cervical areas, compromised aesthetics due to the loss of tooth structure at the cervical margins, and risk of tooth fracture because the deep wedge-shaped lesions in the cervical area of the teeth can increase the risk of tooth fracture due to lowered strength at this critical regions. The next is pulpal damage. Deep cervical lesions are also likely to result in irreversible pulpitis and pulpal necrosis. And caries, non-carious cervical lesions also favor plaque accumulation, which could eventually lead to the development of caries. This is all a secondary damage to the tooth. So what are the treatment options? For tooth sensitivity, the anti-desensitizing agents can be prescribed, restorations, endodontic therapy, and periodontal therapy. So in case of desensitizations, fluoride varnishes or fluoride iontophoresis can be done, dentin bonding agents can be used, and use of a desensitizing toothpaste can be prescribed to the patients. And in case of restorations, considerable loss of enamel and dentin is seen, then we can resort to restoration. Also, in case of aesthetic compliance, we can go for either a GIC or a composite material. So we'll see the advantages and disadvantages of both composite resins and GIC. Composites being superior in aesthetics, it has excellent polishability, high bond strength, and good abrasion resistance when compared to GIC. The disadvantages include technique sensitivity and polymerization shrinkage. The GIC advantages are as good adhesion to the tooth structure. It has a protective fluoride release, good biocompatibility, and the coefficient of thermal expansion is close to the tooth structures. And the disadvantage include less aesthetic because the level of translucency is much lower than compared to composites. It is brittle and sensitive to moisture contamination. The last is endodontic therapy. In case of deep cervical margins, which might occupy the pulpal space, endodontic therapy is to be resorted. And in case of periodontal therapy, there can be root coverages or other periodontal therapies can be inculcated for gingival recession and other mucogingival defects. Thank you.